So next we have up Dr. Jonathan Wong. Dr. Jonathan Wong is a pediatric cardiologist at Sick Kids. He's done fellowships at Boston Children's Hospital, as well as Sick Kids in echocardiography. And he is also a consultant with us over at the Toronto Football Club. It's been very helpful with both our first and second team, but also our academy athletes. So I'd like a warm welcome for Dr. Wong.
Hey everyone. Good morning. Thank you for the introduction. My name is Jonathan Wong. I'm a pediatric cardiologist, and I really want to thank Neil and all the other organizers for inviting me today. My background is not in adult cardiology, so I know a little bit about atherosclerotic cardiovascular disease, but I don't know a ton about that. So my background is actually in acquired and congenital heart disease. But as I was saying, I know a little bit about atherosclerotic cardiovascular disease because I completed a subspecialty training in preventive cardiology and also in echocardiography, which is actually where my interest in sports cardiology originated from. And that was during my preventive cardiology fellowship at Boston Children's Hospital. And there, my practice included different areas of cardiac prevention, like inherited cholesterol disorders in kids, hypertension, but also I worked in their new at the time sports cardiology clinic. But now I've actually left it because I work in private practice where my clinical practice focuses on the identification of children at risk for cardiovascular disease. And for the last year or so, as Neil was saying, I have been acting as a consultant pediatric cardiologist for Channelopathies. So I will be presenting today on pediatric cardiac conditions in sport. So I have no financial interests or relationships to disclose, and I won't be discussing any off-label medication use. I'm not going to need the full 45 minutes, so hopefully you guys have some questions. But I hope to go over the following learning objectives. To compare global approaches to pre-participation screening, to recognize warning signs of cardiac disease in pediatric athletes, to describe key cardiac causes of sudden death in young athletes, and finally to understand the difference between pediatric and the difference between the pediatric and adult athlete with sudden cardiac death. So let's start with a case. This one hits close to home because it's me. I grew up in Toronto. I was a competitive swimmer, a mid-distance freestyler. So I was asymptomatic, thankfully, from a cardiac perspective, and there is no family history of sudden death or cardiomyopathy. However, I never underwent any formal assessment, whether it be through my doctor or through screening as a teen athlete. And then after high school, I obtained a scholarship to swim at the University of Connecticut, and as part of onboarding, prior to even starting my official practices, I and all my teammates underwent cardiac screening, and at the time I thought nothing about it at all. But years later, while I was completing my cardiology training, I wondered why the difference in approach. So, sudden cardiac death is rare. It occurs in 1.9 per 100,000 athlete years. However, it is an important focus of advocacy efforts and clinical research because it's the leading cause of death in sports participation. And importantly, it's often the first manifestation of heart disease. So there are some determinants of risk, those being high risk would be males, Black athletes, and then participating in some high intensity sports like basketball, football. However, the most important thing is that it can affect anyone. So the American Heart Association, the American College of Cardiology, and the European Society of Cardiology all recommend pre-participation cardiac screening to identify high-risk athletes. And that's with the goal to detect silent cardiovascular disease. However, there is no consensus on how cardiac screening should be performed. The American Heart Association does suggest using a 14-point history physical examination checklist that they define as a class 1 recommendation. However, studies have shown that alone, on its own, it actually has quite low sensitivity because most athletes with serious cardiac diseases are asymptomatic and they have no abnormal physical signs or history. There is controversy about the widespread use of electrocardiograms for screening. And that's because of cost-related issues, but it does pick up channelopathies like long QT, Wolff-Parkinson-White syndrome, and most cardiomyopathies also have abnormal ECGs. So generally, pre-participation screening for sudden cardiac death in a child athlete relies on a tiered approach. History physical is the foundation with selective use of ECG, echocardiogram, and other tests, and those can be based on findings and then also based on local guidelines. So all major guidelines, including that of the AHA and the American College of Cardiology, and then also the AAP, the American Academy of Pediatrics, recommend some kind of focused cardiovascular history and physical as the primary screening tool for child athletes. That AHA 14-point checklist that I was telling you about is the gold standard in the US and in Canada, and that aims to identify symptomatic athletes or those with some kind of concerning family history. Like I said, the sensitivity is quite low. It's 10 to 20% for silent cardiac conditions, but this approach is generally universally recommended as the first line of screening. ECGs, as we were talking about before, it does increase the sensitivity of channelopathies, accessory pathways, and cardiomyopathy. And as we discussed, it is generally not recommended for all athletes in the US and Canada due to cost, false positives, and then a need for an expert interpretation. And that's really reserved for those with an abnormal history and physical exam and higher risk patients. However, it looks like that's changing. Echo is not recommended as a routine screening tool for asymptomatic athletes in the US and Canadian guidelines. It is indicated when history, physical, or ECG suggests some kind of possible structural heart disease. But the European Society of Cardiology and some European experts advocate for at least one screening echocardiogram during adolescence to detect structural abnormalities that we don't see on ECG, for example, mitral valve prolapse or coronary anomalies or bicuspid aortic valve. In practice, echocardiography is still second line, and that's reserved for after initial screening. The remaining tests, exercise testing, ambulatory testing, genetic testing, are not recommended as primary screening for asymptomatic athletes, and they are generally reserved for secondary evaluation when initial screening suggests some kind of arrhythmia, inherited disease, or structural abnormality. So this is the, I think you might be able to read that. So this is the AHA 14-point history and physical screening tool I was telling you about. It consists of targeted questions and physical exam elements focused on symptoms, family history, and physical findings associated with underlying cardiac disease. Within the history, there's a focus on identifying cardiac symptomatology, so chest pain, discomfort, tightness, or pressure related to exertion, unexplained syncope, near syncope that isn't vasovagal in origin, excessive or unexplained dyspnea, fatigue, palpitations associated with exercise, and then some physical exam findings or exposure to healthcare providers, so things like a previous history of a heart murmur, elevated systemic blood pressure. For some reason, this person was restricted previously in sports, or there was some previous testing ordered by a physician. Other things related to family history, so family history of premature deaths, of sudden, unexpected, or otherwise before the age of 50, and disability from heart disease in close relatives less than 50, or some kind of identified inherited problem, so hypertrophic or dilated cardiomyopathy, long QT, other channelopathies, Marfan's, arrhythmias, etc. The last 4 questions are related to physical examination. So if you detect a heart murmur that you don't think is innocent, femoral pulses, physical stigmata of Marfan syndrome, and then getting a brachial artery blood pressure. A positive response to any item should then prompt a cardiovascular evaluation. And then, like I was saying, this checklist does remain the cornerstone of US pre-participation screening and is widely used in clinical practice. So how does it differ from around the world? The approaches from around the world for cardiac screening for athletes varies. As we discussed previously, the AHA and ACC recommend pre-participation screening with that 14-point assessment we were talking about. And then again, like we were saying, the ECG screening is not recommended, and that's related to the cost and accuracy. And then reservation of ECG or echo for abnormalities. The AAP takes a slightly different approach. They identify some questions that should be asked to all children, not just athletes. And then they suggest recommended screening every 2 to 3 years, and then at key educational transitions. For Canada, I couldn't find any specific Canadian guidelines, so it's not really detailed in the literature, but Canadian practice generally aligns with the US recommendations and emphasizes history and physical examination for pre-participation screening, and again, reserving ECG for select cases. This is different from Europe. The European Society of Cardiology does recommend a 12-lead ECG, and that's for all competitive athletes under the age of 35. And that's basically because of some data from Italy where they saw that there was a significant reduction in sudden cardiac death incidence after they implemented ECG-based screening. However, this approach requires extensive expertise in athlete ECG interpretation, may increase false positives, and then there's certain populations like Black population that might have some false positives. And then this does mirror some other countries like Denmark who have mandatory sudden cardiac death reporting. So more recently, this is from a scientific statement released by the American Heart Association in 2019, and that actually suggested reevaluation of that 14-point tool. It cited high numbers of false positives, and that's resulting from harboring poor sensitivity and a very low positive predictive value on that 14-point assessment alone. And we actually saw that the ECG alone outperforms that 14-point questionnaire in all measures of statistical performance when interpreted by experienced clinicians. So a notable change in recommendations was seen in a recent scientific statement that was actually from the American Heart Association and published in February of this year, and did kind of shift the recommendation and included ECG as a reasonable addition to that 14-point evaluation. So looks like a bit of tide turning. The main thing to take away from all this, and the reason that there's such variability, is that no screening method is perfect, so there should always have implemented emergency action plans, AED access, and CPR training. So return to that case. While a Division I NCAA collegiate athlete, I should have undergone sudden cardiac death screening, which they did, and thankfully for me it was normal, and they did not implement an ECG at that time. So the second case, this is of a 16-year-old teenage basketball player. He collapses during practice. There was no prodrome. He recovered quickly, and no resuscitation was needed. So let's kind of switch gears and we can discuss the different etiologies of sudden cardiac death in youth. This is a busy slide, but we're going to go through each of them. There is a lot of heterogeneity amongst studies regarding the relative frequency of cardiac conditions based on a number of different things: location, the type of athlete, the age. And however, this pie graph on the right does demonstrate a good one. It's from a US-based population of NCAA athletes. And this was over a 10-year period from 2003 until 2013. and it outlines the relative frequency of possible sudden cardiac death etiologies. These etiologies can then be divided into 3 categories. One being structural abnormalities, 2 being electric cardiac abnormalities, and then the ones that can't be placed other. So going into the structural causes of sudden cardiac death in youth, these can include things like hypertrophic cardiomyopathy, arryhmogenic cardiomyopathy, dilated cardiomyopathy, myocarditis, idiopathic left ventricular hypertrophy, and coronary artery abnormalities. So hypertrophic cardiomyopathy, this is the leading cause of inherited sudden cardiac death in adolescents and represents around 8% or more of sudden cardiac death, and we'll get into that or more statement. It has a prevalence of 0.2% in the general population, and it's defined as having unexplained LVH, so left ventricular hypertrophy, in the absence of some kind of abnormal loading condition like hypertension or something like that. The typical presentation, though, and the thing we learn about is asymmetric septal hypertrophy. So this echocardiogram, it's a still on the right, that demonstrates the asymmetric septal hypertrophy I was talking about, where the ventricular septum is disproportionately hypertrophied, and that's always in comparison to the other wall, so the posterior free wall. You can kind of see that if I have a mouse. Up here, it's being the interventricular septum. This is the right ventricle over here. This is the left ventricle, mitral valve, aortic valve, and then here is the posterior free wall that we're comparing the interventricular septum to. Where am I? Lost my mouse. So this results in left ventricular outflow tract obstruction and symptoms related to that, and also importantly can result in myocardial ischemia, and that's what results in increased propensity to ventricular arrhythmias. So there are some classic examination findings for this one. These occur mainly in the presence of significant septal hypertrophy with the associated LV outflow tract obstruction, and that's that dynamic systolic heart murmur that increases with Valsalva. ECGs are great tools for hypertrophic cardiomyopathy, and the reason for that is that in over 90% of people diagnosed with HCM, there is some kind of ECG abnormalities, and these could include anything from left ventricular hypertrophy, STT wave abnormalities, lateral wave inversions, deep Q wave, left atrial enlargement. So this image on the right is, in the bottom is an ECG from one of our patients with hypertrophic cardiomyopathy, and those show a number of these findings that we were talking about. There is voltage criteria for LVH, there is lateral T wave inversions. It does demonstrate left ventricular strain and then some left atrial enlargement. So, but it's important this is a strikingly abnormal ECG, but it could be anything from normal all the way to all of these things. So there is an important diagnostic conundrum for cardiologists, and this is annoying for us, but a conundrum for us, but is annoying for all athletes. And the reason is that there is an overlap between athlete's heart and hypertrophic cardiomyopathy, where the athlete's heart is a benign physiologic cardiac remodeling that results from intensive training. It occurs with participation in vigorous exercise, and that leads to some moderate increase in left ventricular hypertrophy, along with enlarged cavity size, and then importantly always has normal ventricular function. The most important thing to note about athlete's heart is that it does not carry increased risks of sudden cardiac death, which is very different from things like hypertrophic cardiomyopathy. Athlete's heart is much more common in certain athletes, like those with moderate to large body surface areas, those who take part in endurance sports like rowers or cyclists, and then in black athletes. The annoying and conundrum part of this is that there is, we just talked about HCM being defined as an unexplained left ventricular hypertrophy in the absence of abnormal loading conditions, while athlete's heart results in an increase in LVH, and both likely have normal ventricular function. So this overlap requires thorough investigation done by a cardiologist to differentiate the two entities. And sometimes, which is where the annoyance comes in for the athlete, is that it requires deconditioning. So basically you tell them to stop exercising to prove normalizing of that LV wall thickness to definitively differentiate the two. So we try not to do that, but sometimes it's necessary. ARVC, or arryhmogenic cardiomyopathy, that's another structural heart condition resulting in sudden cardiac death. And that results from a progressive fibro-fatty replacements of the myocardium, and that specifically has that in the right ventricle. So this image on the right, on the top, is a specimen of the right ventricle, which is the ventricle on the left, which is like quite thin-walled, and that's a result of that fibro-fatty replacement. And then underneath that is the pathology demonstrating that. This results in a significant increase in fatal arrhythmias, and that's related to that fibro-fatty replacement, and especially when exercising. So this condition is not that uncommon. It happens in 1 in 1,000 in the general population, and is a major cause of sudden cardiac death in athletes. In that previous slide, representing around 5% of events. So this is actually one of the prominent etiologies in athletes who die while exercising rather than peri-exercise. And most are diagnosed, and most who are diagnosed with this condition, which is quite in odds to other conditions, are told not to take part in vigorous exercise. I'm going to quickly go over some of the other ones I discussed, but not go over them fully. The other structural ones would include dilated cardiomyopathy. That's relatively rare and around 1 to 3%. It is defined as left ventricular dilation plus systolic dysfunction, and does carry a risk of serious ventricular arrhythmias. Dilated cardiomyopathies demonstrated on the top right picture. If you think about that previous echo we're looking at, the cavity is like strikingly much more dilated. We can't comment on function because it doesn't move, but that is a dilated left ventricle. Myocarditis, that happens in more. It's around 2 to 9% of sudden cardiac death in youth. It's an inflammatory disease of the myocardium. It's often related to viral infections. However, there are a number of other causes, and again, that adds risk of fatal arrhythmias. The third etiology on this slide is an interesting one: idiopathic left ventricular hypertrophy. This is a novel entity, and that is actually being increased more and more in the literature. On that pie graph, it was 8%, but you can find it in the literature upwards of 30%. And this is all because there is a significant overlap with cardiomyopathy, specifically hypertrophic cardiomyopathy. Importantly, it's not related to athletic training, so it's not similar to athlete's heart in that way. And there is a school of thought that this is actually representing early evolving hypertrophic cardiomyopathy, which is why there's such a large percentage of the population there. And this is why I said that the HCM is at least that 9% we were discussing. The middle picture on the right demonstrates idiopathic left ventricular hypertrophy by specimen. You can see how striking this one is. The last one on this slide is anomalous coronary artery origins. That's basically where there's some kind of anomalous origin, generally of the left coronary artery, where it originates from somewhere else, like a different sinus. Generally, that's from the right sinus, and then it courses back to the left side in between the pulmonary artery and the aorta, so an interarterial course. and often an intramural course, which means it crosses through the actual mural part of the leaflet. This can present with symptoms like those symptoms we were discussing, like exertional chest pain or syncope, and does generally have ECG abnormalities. So let's return to the second case. So on focused history, he had never had any previous symptoms or events. He has no family history of sudden death or cardiac disease, and he had no previous testing. When someone listened to his precordium, there was a systolic murmur, and that actually got louder with Valsalva. His ECG revealed left ventricular hypertrophy with some deep Q waves. And then the echocardiogram, which I'm showing on the right there, demonstrates that there is asymmetric septal hypertrophy. That's best viewed in the peripheral view, which is this one here, where you can see much more hypertrophy in that in between the right and left ventricles down that posterior free wall. And that was measured around almost 2 centimeters, and then this patient had an LVOT gradient of around 40 millimeters of mercury mean. So this was consistent with hypertrophic cardiomyopathy. The third case is a 14-year-old who's a rower. So while she was in a race, she collapses mid-race. Similarly, she gets back up, no resuscitation needed, and as part of her workup, she gets an ECG, and the ECG, after correcting the QT interval, revealed a QT of 520 milliseconds. So this kind of transitions us to the second group. Those are electrical cardiac causes of sudden death in youth. Causes can include long QT syndrome, brugada syndrome, CPVT, and Wolff-Parkinson-like. So long QT syndrome, it's a genetic channelopathy, and that's characterized by prolonged ventricular repolarization. That's defined in post-pubertal teens as having a corrected QT interval of greater than 480 milliseconds in females and greater than 470 milliseconds in males. But the highest risk of arrhythmia really comes once that QT is greater than 500 milliseconds. So this condition carries a propensity for life-threatening ventricular arrhythmias, and especially during sport, and can account for around 3% or more of sudden cardiac death. There are triggers, and triggers are based on the type of long QT syndrome, but those can include anything from adrenergic surges related to emotional stress in athletes or electrolyte disturbances that it also is present in athletes. So this condition is inherited as primarily, with the exception of one, autosomal dominant, and there are a number of different causes, not just 3 that I've listed on the right, but the top 3 are the most common, and these are them on the right, which I didn't go into any further. There are other electric causes of sudden cardiac death. They generally are rare, and most of them representing less than 1%. Things like brugada syndrome. Brugada syndrome is an inherited channelopathy that affects sodium channels, and that results in ECG abnormalities that can often be seen. That is demonstrated on the right with where you can see that there are a cove-type ST elevation, and then some kind of varying degree of right bundle branch block. Brugada syndrome has a large propensity for fatal ventricular arrhythmias and sudden death, and then the key words for these are that it happens when people have their temperature increase. So when they're sick, like having a fever, but also when they're exercising. Catecholanmineric polymorphic ventricular tachycardia, we call that CPVT. It is less than 1% as well, and that is inherited arrhythmia that results in stress-induced bidirectional VT. The importance feature of this is that, and it's a scary feature for most people, and that's that it has a normal baseline ECG, but does have some kind of presence during exercise tests. And so during exercise tests, you often see bidirectional PVCs, and that's what this middle image on the right demonstrates. The last condition is Wolff-Parkinson-White. Wolff-Parkinson-White syndrome, I think, is overrepresented in the that pie graph we were talking about. That is around 3%, but generally is showing up less than 1%. That is shown with a recognizable ECG pattern. That's the Wolff-Parkinson-White pattern. That's where you have ventricular pre-excitation, which we define as a short PR interval and then a delta wave, so that upslurring of the QRS segment, with some kind of documented SVT. So that's how you go from Wolff-Parkinson-White pattern to Wolff-Parkinson-White syndrome. This does carry a low risk of malignant arrhythmia, and what I would like to highlight as well is that that's Wolff-Parkinson-White syndrome. SVT generally doesn't carry a risk of sudden death unless it's associated with that. So that third case, returning back to it, so she had no previous syncopal episodes on history. She had no cardiac symptoms. When asking about family history, you elucidate that there is a cousin who died suddenly while swimming. The rest of her assessment is pretty normal. She has physical examination. Her echo was normal, but we did see on that previous slide that her QT was prolonged. So she was sent for genetic testing. She was identified to have a KCNQ1 mutation, which is the mutation for long QT1. There is the mishmash of other cardiac conditions in the third group. That's the other group. And we're going to talk about those last, and that is commotio cordis, valvular heart disease, and aortic dissection. So commotio cordis has been in the news recently. That was, I'm sure all of you remember, when the American professional football player Damar Hamlin collapsed by cardiac arrest. And that was during a nationally televised NFL game, which really brought commotio cordis back to the forefront. But it is important to notice that commotio cordis is a rare cause of sudden cardiac death, and it is related to some kind of sudden blow to the precordium. It's actually more common in children and adolescents, and that's really due to the fact that children and adolescents have more of a compliant chest wall. So this figure on the right actually really nicely outlines a lot of what you need to know about commotio cordis. Where the pathophysiology is related to some kind of sudden blow, and that's at the onset of the T wave. So you see this is normal QRS, P, QRS, T, P, QRS, T, and then P, QRS, and then on the upstroke of the T wave, there's some kind of blow to the chest, which can trigger the patient to go into ventricular fibrillation. There are a number of features that really are determinants of if this is going to happen, and those are related to the source of the blow, like what kind of tool it is, like a hockey puck or a lacrosse ball or fist or baseball, but also related to the site of the impact, the timing in the cardiac cycle, and then variables that are really associated with the projectile. And those are the really key determinants of if someone's going to get commotio cordis. Other cardiac causes, the other two that I mentioned there were valvular heart disease and aortic dissection. The first valvular heart disease that has apparently been reported as increasing risk of heart disease, sudden cardiac death, is mitral valve prolapse. The reason I say apparently is that mitral valve prolapse is incredibly common in the general population, and not everyone with mitral valve prolapse gets sudden cardiac death. It can rarely be associated with some kind of malignant arrhythmia, and it's the factors associated with that are generally some worrying factors you'll get on history. So things like significant family history of sudden death or something like that, ECG abnormalities, specifically inferior T wave inversion. You can see QT prolongation, and then ventricular extrasystoles, so PVCs, and then you could actually define where the PVCs come from. If they come from a mitral area, then that would be indicative of that. On the other hand, bicuspid aortic valve, there's a recent study that came out that suggests that in all sudden cardiac death, around 1% of patients have a bicuspid aortic valve. And when they dig deeper into that, they see that some are related to significant aortic stenosis, so causing the disease, and then some are related to it being incidental findings. So that has sparked some interest to elucidate if this is some kind of risk that needs to be greater determined. The other thing is aortic dissection. Aortic dissection is a rare cause of sudden cardiac death. It's reported in that pie graph we were showing before, around 5%. And that is often related to static exercise, where generally it's like with weight training and things like that, where you have this rapid increase of blood pressure. That increase in blood pressure could possibly lead to aortic dilation. And then notably, people with Marfan syndrome, which is an inherited connective tissue disorder, and results in tall patients, so they have a higher predilection to sport, and they end up in basketball, volleyball, things like that. And Marfan syndrome is associated with some things, but most importantly, progressive aortic root dilation, and then they carry a risk of aortic dissection. So we've outlined the predominant etiologies of sudden cardiac death in youth and recommended screening practices. This is generally the approach in children and young adults, so what people take below the age of 35. However, over 35, adults take a different approach, and that's really focuses on the detection and risk stratification of coronary artery disease, so coronary risk related to atherosclerotic cardiovascular disease. And that's because that's the main etiology and the predominant etiology in adults. And this is very different from children that we outlined over the last 40 minutes, where there's a number of different causes that require much more of a workup and often are related to inherited or congenital cardiac conditions. So that common saying in pediatric does ring true here, where the children are not just small adults. So finally, with just the last slide or two, I wanted to just quickly outline what you do with a young athlete who's diagnosed with a cardiac disease. Traditionally, there has been very restrictive guidelines, and that's resulted in almost universal contraindication to sport. And that's actually, over the last decade or so, really taken a change, and that's really sliding across the scale where they're currently being much more liberal. And instead of taking a restrictive approach, the current approach focuses a lot on promoting shared decision making. So you're getting input from all the stakeholders for this patient, so the athlete, the family, and the medical team. And the approach really goes from like blanket restriction to more of an individualized based on disease and type and severity of the disease. And that's really where the team must weigh the benefits of sport and exercise, and then also that individual patient's risk of sudden death. So the goal for us all should be to encourage safe, inclusive sport wherever possible. And then just in terms of a few takeaways, I'd like to outline these last four. The first is that pediatric athletes are generally safe to play, most of them. Screening aims to identify risk of disease, not to disqualify athletes. Practitioners should recognize red flags early and then refer appropriately. And then we should promote safe participation, and that's really through collaboration. That's it. Any questions?
Thank you. Great. Just two quick questions, I hope. So one is, could you comment quickly on precordial catch syndrome? And then the other one is, so things in medicine obviously become very fashionable, and I think everybody wants to have Ehlers-Danlos now, right? So what's your approach to maybe somebody that doesn't meet criteria for Ehlers, but there's definitely some ligamentous laxity there?
You asked two really hard questions. Precordial catch syndrome. I think the most important thing to remember about precordial catch syndrome is that when you look for these red flags, you generally don't have them. This generally doesn't happen with exercise. It can happen randomly, sometimes with, sometimes without exercise. It's generally not associated with other cardiac problems like syncope, palpitations, exercise intolerance. And they generally have they don't have any worrying past medical or family history. So my approach to precordial catch, along with most other non-cardiac causes of chest pain, is really reassurance. I reassure through investigation, show them ECGs that are normal, echocardiograms that are normal, and that's totally biased given the fact that I could just do that and that it's limited for other people, but also reassurance and then suggesting continuing the sport. Ehlers-Danlos, I am certainly not an expert in connective tissue disorders. There is important considerations with Ehlers-Danlos, and that is that there is a small subset that's called vascular Ehlers-Danlos. So those patients do get abnormal problems. They get the same things as Marfan syndrome. They get mitral valve prolapse that can result in significant mitral regurgitation. They get aortic root dilation. And that aortic root dilation is much more severe than it is in Marfan syndrome. So despite taking beta blockers, which are often the first line therapy, or Sartan, they continue to compress to get worse, and then a lot require aortic root surgery. That's very different from, like, I think it could be called like Ehlers-Danlos 2, where you're like, it doesn't meet criteria. They often are not related to any underlying cardiac manifestation. So I think in those patients where they aren't, that you like very clearly aren't like that one severe group, again, it's reassurance, ensuring that their cardiac examination and even echocardiogram are normal, and providing lots of reassurance, because a lot of these families are just looking for reassurance. I hope that answers your question.
Hey, John. Hey, if you were to introduce a cardiac screening program in a pediatric athletic population, do you have any recommendations or evidence on what age you would think would be appropriate to start that, and then the interval years, how often to screen that population?
Yeah, so I think the reason I mentioned the American Academy of Pediatrics simplified version that they have, they use a good approach in the sense of transition. Like when you're transitioning from a lower level of sport up to a more competitive level, and generally most sports have this. Like I remember as a swimmer, it's like when it went to a very competitive level, you kind of know. You go to the highest group, you're swimming much more. So during transitions would be a good time for the first screening. I think for most part, it should be adolescence to early teenage years, especially now we see that like the specialization and lots of training happening early. And then the question about frequency, I think ensuring they have adequate follow-up, they are seeing a doctor, because in those middle childhood years, there's lots of research that shows that kids, especially in Canada, don't see doctors. They don't do their annual health visit like they do in the US. They come at 14 to 16 when they're mandated to get their vaccines, and then they aren't seen again for a number of years after that. That obviously depends on clinical practice, but making sure that athletes get regular assessments by their primary care doctors is really important. I don't think that getting regular ECGs is necessary, but getting, like, being seen by a doctor, getting histories taken, and doing a focused physical exam is really important.
Hi, I am a adolescent medicine doctor in the U.S. and half my practice is primary care. And like you just mentioned, in the U.S. we are seeing these patients every year for their sports clearances. So the question I have is, in terms of we ask these 14 questions. It's either in the survey or done part of the review systems. But to be honest, if I ask 100 12 or 13-year-olds, do you ever have chest pain? 40% are going to say yes. So can is there any data that kind of dials down, okay, the follow-up questions like pain just on exertion, and what kind of pain that would kind of filter out who needs to actually go to see a cardiologist for the EKG versus the ones that we can just say that's nothing.
There is I should have included this. It's actually on the slide, but I cut it down. The American Academy of Pediatrics also has like a definition in that same publication that I can provide to you, where they talk about atypical chest pain and how to define atypical chest pain. It does focus on a lot of things that are in that 14-point guide, focusing on it being related to exercise, which is a huge red flag and should always warrant investigation, and it not being related to some other cause, so like happening at rest, a sharp pain, not having a crushing sensation. I find the traditional way we're taught about good cardiac chest pain versus non-cardiac chest pain, so like localization for type, so sharp versus crushing, or radiation down to the arm or things like that are very useful. And then anytime that those red flags come about, they should have a cardiac assessment. And I would say in most others, unless it is refractory, like if you continue to see it over a number of different visits, then you probably don't need to have additional assessments done.
Hey, John, sorry. Thanks for the talk. I think that's a great review for all our fellows and people in the room that are regular CASM exams. So it's really a great talk. I have a few questions specifically on things you talked about. The first in myocarditis, the risk of arrhythmia, fetal arrhythmia, is that just while they're unwell, or is that like a lifelong risk?
It's not lifelong. It is while they are in the acute phase of myocarditis. The main thing to remember about myocarditis is that it is an inflammatory condition. There is a period where you have decreased function, you have widespread ECG changes. During that time, people should not be exercising, and they do carry a significant risk of ventricular arrhythmia. The problem is that some people have asymptomatic viral infections and then don't know they have myocarditis, and that's where screening comes. But after the initial acute inflammation, there's kind of a number of different phenotypes, but really there's two main ones. The first is that you get better, your function resolves, you are back to normal, you don't carry a risk anymore of fatal arrhythmia during that time. But the other group is that myocarditis can often then turn into other forms of cardiomyopathy. So go into dilated cardiomyopathy specifically. And there are and dilated cardiomyopathy does carry a risk of fatal arrhythmia.
Thank you very much, John.